So if the hip is going to now go into internal rotation, where does the hip need to be? Less than 60. Because the hip less than 60 is an external rotator. All right, so if you're going to try it, you could even, some people could use this as a stretch. You could actually use this as a stretch release by getting on the piriformis doing this way, so that's okay. But you have to keep in mind where you are in the degree of hip flexion. The reason this is a special test is because from right here, if I hold it up, pelvis is here, as the patient relaxes, as this drops down, the piriformis is now passively lengthening, so it is tensing over the sciatic nerve. So one of the symptoms is pain at the interface or potentially tingling in the feet. And that would just be from the passive overpressure, but you could also hold the iliac crest and say, okay, gently lift this knee up into my hand. So he's contracting into external rotation, contracting the piriformis, so now it's tensing because of a contraction. Okay? So keep that in mind that you could do that as a test. Lie on your back for me. You could do the same thing right here. Flex, adduct. Now I'm externally rotating, but I'm tensing the piriformis, and now I can add the nerve. Yeah. So it's one of the ways that you can start to get that differential of muscular, dural, or articular. Okay? For right now, the differential that you're applying when you're doing the muscle length test is basically by end feel. If I feel a capsular, firm end feel, then I'm thinking articular. If I feel a muscular, giving end feel, then that's muscular. Okay? Okay. Oops. That was just to point out the correlation there. We're not going back to special tests. Okay. The ITB, oh, no, supine. Okay. So this test is the hip flexor length test or the Thomas test. It is described in two different ways. The original way the Thomas test was described, it was just done on the bed flat like this. So what you do is you're going to bend this knee. You're going to start with both knees bent, and you're going to bring this knee up towards your chest, hug the knee. You're flattening the back into the bed. Okay, that now sets the baseline of what you're doing for the hip flexor lengthening. Because you hear other people that will describe keeping the back in neutral. Okay, so neutral is a bit of lumbar extension. That's lordosis. So if we flatten the back into the bed, holding there, now slide this leg straight. And the back of the thigh should go all the way onto the bed. Okay there? Mm-hmm. Any pull?
Not really.
I think we're just running into muscle. That's the limitation here. So to me, I don't feel like we really truly have a sense of the end range. So the other version, which now is called the REC-FEM test, comes down to the edge of the bed. We have to change the name for every test, apparently. See, yeah. They're sitting at the edge of the bed, okay? And now you're going to bring one knee up towards your chest, and you're going to roll back, okay? Now you see why the one on the bed is a little more practical for a majority of your patients. Does that make sense? Because that maneuver, there are plenty of patients that can't do that. And you're often checking this with patients who have low back pain. All right, so you're not going to ask them to do that. So doing the version on the bed, the original Thomas test, makes perfect sense. However, it doesn't give you a full sense of the REC-FEM length. So this one, you want the knee to stay bent at 90 degrees, and you're going to say, okay, allow the leg to lower down, allow it to go down, allow it to go down. And it needs to pass the horizontal. With the back flat, it needs to pass the horizontal with the knee at 90. If we extend the knee, and he drops down further, then it shows that the first limitation that we ran into was REC-FEM. Because now when we straighten the knee, we relax the REC-FEM. Okay, come back up. So dropping down, at this point, we're getting a sense of the length of the REC-FEM. I'd say we're probably a little shy, but it's not bad. And then when we straighten the knee, we see that he drops down further. So we're not faced with hip flexor shortness or tightness. Okay? But we are with a little bit of REC-FEM. The other thing that can happen is that when they start to lower the leg at 90 degrees, it moves out. It abducts. If the leg abducts, it's because they're compensating for tension of the tensor fascia lata muscle. Okay? Because it's a flexor and an abductor. So as I'm moving into extension, it's starting to tense, and then it's saying, no, I don't like that. So it'll abduct, in other words, move into the shortened position of one of its motions. Okay? So from here, and you guys, as you do this, you're going to talk each other through it, because I want you to understand the different compensations that can happen. 90 degrees, as they're lowering down, if they're in line, everything is straight, knee stays at 90, they should get to horizontal. That's the length of the rec fem. If we straighten the knee, we take the rec fem out of it because we shortened it over the knee. So now we're getting a sense of the hip flexor length. So if they're here and we straighten the knee and they don't go anywhere, we know we're faced with hip flexor shortness or tightness.
Do you know how much lower should they go for
Hard-
flexor, or is it
hard-
just below hard?
No, so in other words, this is showing up with a little bit of rec fem tightness, but it's pretty close. They need to go to the horizontal. The texts that write 10 degrees below horizontal, it's because the low back is in lordosis. Okay? If the knee abducts, they're compensating for TFL. Okay? All right, practice the Thomas test. On the bed and then off the bed.